Thank you for choosing Axxess On Demand. We're the fastest growing home health technology company, helping improve care for more than 1.5 million patients and trusted by more than 7,000 healthcare organizations to grow their business. Axxess is a firm believer in continuing training, and we create content so you can learn and grow anywhere, anytime. Let's get started.
Hello there, and welcome to Axxess's Conditions of Participation webinar series. My name is Jennifer Gibson. I'm a registered nurse, and I am Oasis and coding credentialed for home health care. And I'm here to guide you through part 2 of our 7-part series on the conditions of participation. Today we're going to talk about and learn about the patient rights and the comprehensive assessment. Our objectives today are to learn the 6 standards of patient rights, to understand the timelines for notice of these patient rights, to verbalize the role of the patient-chosen representative versus the legal representative. We're going to learn CMS's rules regarding transfer and discharge, and we're going to understand the agency's responsibility in handling of complaints and the exercise of rights. And then in the last part of this section, we're going to also talk about the comprehensive assessment to become knowledgeable in the requirements for initial assessment and comprehensive assessment. CMS has stated the goal of these updated COPs is to achieve better health and better patient outcomes. Certainly, knowing that as a patient you have the right to be involved in your care, to help develop your plan of care and state your goals, to know who to talk to when you have concerns, and being able to communicate effectively is a huge factor in achieving that mission. You'll find the Subpart B, Patient Care, under Section 484, Home Health Services. That's the general part for the COPs for home health services. Subpart B is Patient Care, and 484.50 is where we find the patient rights. And you'll see 484.55 follows with the comprehensive assessment of patients. But for now, we're going to go ahead and look into the patient rights. Now, there are 6 standards for patient rights in the new COPs, and you're going to see those on the headings of the slides as we continue through our webinar today. But the 6 standards are, number 1, the notice of rights; number 2, the exercise of rights; number 3, the rights of the patient; number 4, transfer and discharge; number 5, investigation of complaints; and number 6, accessibility. At 484.50 in the patient rights section, we first see a preamble that simply states the patient and the representative, if any, have the right to be informed of the patient's rights in a language and manner the individual understands. The agency must protect and promote the exercise of these rights. Now, you're going to notice the introduction of a patient representative here, okay? The definition of a representative as stated in Subpart A, which we went over just a little bit in our last webinar. The representative is the patient's legal guardian or other person who participates in making decisions related to the patient's care or well-being. And that includes, but it's not limited to, a person chosen by the patient or a family member or an advocate for the patient, but someone who's helping with that patient's rights, exercise, and also the care delivery. Now, the patient gets to determine the role of that patient representative to the extent possible, unless it's a legal document. We're going to talk about that in just a moment. But the patient gets to talk about or determine whether or not that representative is involved with all aspects of his or her care. Now, one thing that we're going to see as we go forward in the next few slides, that the notification of rights have to be in a language and manner that the individual understands. So in other words, the patient and the representative would have the same right to be informed in the language and the manner that they understand. Both have to be given notice under the new regulation. Currently, these are your G tags, G100 and G101. Whenever July 13th comes, I don't know if those will stay the same G tags or change, but certainly the regulation will be updated a little bit. And normally what happens when the surveyor comes in, the surveyors ask the patients if the agencies have informed them of their rights, and then they ask how they did that. The patient should be able to give examples of how the rights apply to their care and their concerns, like their finances, their accesses to services, and the home health agency hotline. So what you're going to see, and what we don't have just yet, we do not have interpretive guidance, which is what the surveyors use to conduct their surveys in our agency. And the Interpretive Guidance is another manual that comes out to help agencies understand what we're going to be graded on specifically. That has not come out yet as of the date of this recording. I talked to a representative at CHAP last week, and they were not sure. What they had heard through the rumor mill was that we may not get those until after our July 13th implementation date. So we have to kind of look a little bit about what the surveyors have done in the past, look at the new regulation, and do our best guess until those interpretive guidelines come out. And certainly if there are major updates to what we've taught you in the webinar series, Axxess will go ahead and update you on that surveyor guidance as well, okay? You'll notice at 484.50A, there's a standard called Notice of Rights, and the agency must provide the patient and the patient's legal representative, if any, the following information during the initial visit in advance of furnishing care to the patient. Notice there are several timelines in the new conditions of participation that we have to meet as they relate to the patient rights. You're going to see wording like during the initial evaluation visit, in advance of furnishing care to the patient, before care is initiated, in advance of the next home health visit, and then by second skilled visit. And you'll even see within the 4th business day after the initial assessment. So we have lots of timelines to keep up with, and you'll have to build your policies and processes and procedures around how you're going to handle these different timelines as an agency. We're also going to see that surveyors currently look at a sample of records and note that patients' rights, including the Oasis reporting and collection, have been given prior to care being initiated. So as we see here at 484.50A, for the patient and their legal representative, that's going to be like a durable power of attorney for health care, or a patient who has a living will, if there's somebody that's designated in that living will to make decisions for that patient, then we have to make sure that the notice of rights is given to that patient and that patient's legal representative, if they have one, all the information that we're about to see on the next slide during the initial evaluation visit, in advance of furnishing care to the patient. And that really hasn't changed. The only thing that's different is we're really talking about the difference between a patient-appointed representative and a legal representative at this point. So on the initial evaluation visit, we should make sure that we are giving notice of rights, and here's what we have to give. Number 1, a written notice of the patient's rights and responsibilities, a written notice of the agency's transfer and discharge policies, contact information for the home health agency administrator, an Oasis privacy notice for all patients for whom the Oasis data is provided, and then we have to obtain the patient or legal representative's signature confirming receipt of the copy of the Notice of Rights and Responsibilities. Now again, this is the same as what we currently have for our regulation. The difference, again, is just differentiating between that legal representative and the patient-appointed representative. The new COPs, however, tell us that these things must be provided to the patient and that patient's legal representative, if they have one, on the initial visit. These rights have to be provided in written format, understandable to people who have limited English proficiency. They must also be provided to the patient and the patient's legal representative before any care is furnished. That means hands-on care or any kind of education or training, any kind of assessment, any kind of care at all. They have to be notified of these rights in written form. If the patient doesn't have a legal representative, but they name a representative such as a neighbor, then that patient can choose whether or not that representative gets informed of rights as well, but that timeline is a little bit different, and we're going to see that in just a moment. The written information has to be provided in alternate formats free of charge for persons who have disabilities when necessary in order to achieve necessary communication. For example, they may have to have Braille for persons who are blind, or large font if your patient is legally blind, and so on. One of the newest things in the COPs has to do with that contact information for the home health agency administrator, that third bullet down. And so this is in addition to the home health hotline. We have to make sure the patient knows who the home health administrator is, including their name, their business address and their business phone number so that that administrator can receive complaints as well. And I don't know about you, but for me, I would much rather the patient call me as an administrator than go straight to that home health hotline, because I have a chance to rectify the situation or take that complaint and make sure the patient is satisfied without a surveyor coming in to see what the problem is, should they call my 800 state hotline, right? And to me, that's a good protection for the patient, and it also is a good protection for the agency and gives us a chance to make sure the patient is happy and know what's going on if there's an issue with the patient's care. Again, just to repeat, all of this must be done before care begins for that patient. By the end of the second visit, we have to give a verbal notice of the patient's rights and responsibilities. Now, when I was reading the COPs and looking at the comments and the responses from agencies and CMS, one of the things that was brought up, and I think that's why they finalized this change in the final rule, is that there was some concern about whether or not the patient and the representatives could be informed verbally and in writing and in all these different languages and all these different formats of the patient's rights and do that effectively. And there were some concerns that that wouldn't be the case. So CMS was kind enough to break this out into some timelines. Now, the timelines, they do not mean you have to wait until the fourth day or the second day. If you can handle all of this on the initial evaluation visit, you can take care of all of these notifications of rights. However, one of the commenters, and I think this is probably true, said that a lot of times it's overwhelming for that patient and the caregiver to get a written list of rights and then to actually go over those rights with the patient on the first visit and then go over all the other information the patient needs regarding their care and what's immediately needed to take care of the patient and so on. So for that reason, CMS broke it out into having the written part given on initial evaluation, and by the end of the second visit, being able to give that verbal notice to the patient and their representative. So the written part's already done, the second visit happens, and verbal notice of that patient's rights and responsibilities have to be given, and it has to be in the individual's primary or preferred language, in a manner that the individual understands. It has to be free of charge, and we will have to use a competent interpreter if necessary, and we have to make sure all of this is done no later than the completion of the second visit from a skilled professional. And what is a skilled professional according to 484.75 of the COPs? That is a skilled nurse, a physical therapist, a speech-language pathologist, an occupational therapist, a physician, a medical social worker. And it doesn't matter if these visits are made under the skilled professionals who work directly for your company or they're under arrangement or contract. This still has to be done by the end of that second skilled visit, okay? So meeting this requirement is going to take some prerequisite research and information about that patient. You'll need to find out if English is not the patient's primary language. Then how are you going to arrange to make sure you can give a verbal understanding of the patient's rights in their language in a manner that they understand and free of charge, right? So you need to figure all that out. They can use, if they want to, they can use their own interpreter. We need to ensure that that interpreter's competent, and that can be difficult if you don't speak the language to see what they're telling the patient. And for that reason, personally, I believe a professional interpreter service is a better choice. However, the patient does have the right to say, no, I don't want to use that service. I'd rather use my daughter or my son or whatever, okay? Again, coordination of care is going to be really important here because the discipline who does the initial evaluation and or the comprehensive assessment is going to need to find out the patient's primary or preferred language. That will need to be communicated to their supervisor, possibly the newly established clinical coordinator, so that the interpreter or interpreter telephone service can be set up for that second visit. And if the second visit, of course, is made by a discipline or skilled nurse who's not the same as the person doing the admission visit, then all of that has to be coordinated so that the second discipline who goes out for that second visit understands this has to be completed by the end, who to call to set up the interpretation services. All of that has to be coordinated to ensure that this right is met. And then, of course, at the end of the second visit, all of this would need to be documented in the patient's chart by the discipline who went out, ensuring that all of this happened and documenting that it did. And then within the fourth business day, After the comprehensive assessment, the agency has to provide written notice of the patient's rights and responsibilities under this rule and the agency's transfer and discharge policies that are set forth in paragraph D, that'll be coming along in a little bit, to the patient-selected representative. So what does that mean? So on admission, if the patient did not have a legal power of attorney and we didn't give that legal power of attorney a written notice of their patient's rights, then within 4 business days, if it's a neighbor or a friend, we have to coordinate in a way that we can give a written notice to whoever that patient representative is. Okay, so this is not a legal representative. This is a patient-selected representative. We have to make sure that we can get written notice of the patient's rights and responsibilities to this person. Now, that can either be on a visit, and that representative is in the home. Or you can also make arrangements to deliver that by mail. And if that's the route I choose to go for some reason, I would mail that in a way that I get a receipt or a signature that that person has received this and keep that in the patient's chart. That's personally what I would do to make sure that it happened. Now, again, the patient can opt out of having this patient-selected representative notified. So you'll need to let the patient know. I'll also need to let your friend or your caregiver or your neighbor or your family member, whatever, a copy of these rights that I'm giving you today. So in other words, is that what you would like, or would you like me to go ahead and give them the rights, or do you want to not have that caregiver notified of the rights? This patient-selected representative only gets to work within what the patient decides they can do, okay, if that makes sense. So all of that information has to do with the Notice of Rights, which is the first of the 6 different rights standards. So the next part is the exercise of rights, and that's number 2 of the 6 new rights standards, the exercise of rights. This standard lays out who can exercise that patient's rights. Now, the standard actually reads, and we're going to see it on the next slide, that if the patient has been adjudged to lack legal capacity to make healthcare decisions as established by state law by a court of proper jurisdiction, the rights of the patient may be exercised by a person appointed by the state court to act on the patient's behalf. All right, so what this says in the overview here is if the courts have judged the patient lacks legal capacity to make healthcare decisions, then the rights of the patients can be exercised by the person appointed by the state court to act on the patient's behalf. So again, we're looking at coordination of care. The agency is going to need to know what the court order states, and they would need to follow those orders. You'd have to make sure you document attempts to obtain that information, clarify the information, conversations with others about obtaining the information that you need to see what the courts have judged, and then ensure that the entire team that's delivering care to that patient knows to what extent that patient can exercise his or her rights and who is legally appointed to make decisions for the patient. And again, that includes staff that's directly employed or those under arrangement or contract. So again, assess whether or not the patient's competent to make healthcare decisions. That would be something that can begin at the very beginning at referral intake. If you see the patient especially has a diagnosis of dementia or a psychiatric illness or something like that, that's your first clue to start asking questions. Is the patient legally competent? Is there any kind of legal documents on file there at the hospital or the facility that you can forward to me about the patient's competency level and who might be making those decisions for the patient? And then once you get those papers, you'd need to review them and see if the patient has been adjudged to lack the legal capacity to make their own healthcare decisions by state law. And if so, who is appointed to make those decisions for the patient, and to what extent is the patient allowed to exercise his or her rights? Okay, and just to review, at 484.50b, 1. If the courts have judged the patient lacks legal capacity to make healthcare decisions, the rights of the patient may be exercised by the person appointed by the state court to act on the patient's behalf. The second bullet point that we have here, if the courts have not judged that the patient lacks legal capacity to make healthcare decisions, then anyone chosen by the patient can exercise the patient's rights in accordance with the patient's preferences. And if a patient has been judged to lack legal capacity to make healthcare decisions under state law by a court of proper jurisdiction, the patient may exercise his or her rights to the extent allowed by court order. Even with the judgment that that patient lacks a full legal capacity to make decisions, sometimes the patient can exercise part of their rights that are allowed by the court order, and you'll have to get a copy of the court order to be able to follow it and know what the patient can do and can't do. For example, the patient might be able to make complaints about the care that's going on in the home, but he may not be able to give consent for treatment, if that makes sense. So again, you're going to have to get that court order to find out what's going on. The next standard, which is the third of the 6 standards of the patient rights, is the actual rights of the patient. Now, these are currently found in the COPs at 484.10, and you're going to see that they've been moved over to the 484.50 section of the conditions of participation. Now, what we see here are these several rights that we have to make sure we ensure the patient is able to exercise, and they're notified of these rights. These are the rights we're talking about. Number 1, the patient has the right to have his or her property and person treated with respect. The patient has the right to be free from verbal, mental, sexual, and physical abuse, including injuries of unknown source, neglect, and misappropriation of property. And that's a new term, by the way, that we're going to talk about in just a moment, injuries of unknown source. So hang with me and just know that's new terminology. The third right, the patient has the right to make complaints to the agency regarding treatment or care that is or fails to be furnished, and the lack of respect for property and or person by anyone who is furnishing services on behalf of the agency. The next right, the patient has the right to participate in, be informed about, and consent or refuse care in advance of and during treatment where appropriate with respect to the completion of all assessments, not just the initial assessment, but research, follow-ups, transfer assessments, and so on. The care to be furnished based on the comprehensive assessment, establishing and revising the plan of care, the disciplines that will furnish the care, and the frequency of visits. Now, what does that mean? The patient has the right to be informed about, consent to, or refuse care in advance of and during treatment, including the assessment itself. Now, clearly, CMS expects the assessing clinician to have an overall understanding of that patient's condition in order to formulate a plan of care with the physician. This can't be properly executed if the assessing clinician just makes a visit and fills out an Oasis, right? And then they try and turn that into the office where some reviewer sequences all the diagnoses and writes interventions and goals. If the patient has the right to participate in the completion of those assessments and the care that's going to be furnished and establishing and revising that plan of care and who's going to be coming and how often and what they're going to be doing and what are the outcomes, all of that needs to be established on that assessment, initial assessment and admission visit, right? Can't wait until after the fact and tell the patient. You got to do this initially. That assessing clinician is going to have to formulate the plan at the start of care, talk to the patient, inform them about the plan of care, like what disciplines are coming, what they're going to do, how often they're going to visit, what are the expected outcomes or goals, and what factors might impact the care. This is an ongoing standard. Each discipline will have to review the plan of care with the patient, explain treatments before they're performed, and explain procedures and risks and outcomes and factors that might impact the care. And then you're going to have to notify the patient of any changes in that plan of care and frequency. And again, this is not really something that's new. It's worded a bit differently, but all of us learned in our respective professional institutions of learning and in our professional trainings, in our practice acts. Part of what we do is assessing patients and informing them of treatments and what we're going to do to the patient and how it's going to happen. All of that should be second nature to us already. It's part of what we do. I think one thing that's lacking because we're not a brick and mortar supervised setting, sometimes we think home care is so different, but we still need to be doing our care planning and really figuring out what this patient needs and how we're going to meet those needs and have good outcomes. And that's really what the COPs are striving to do here, in my opinion. So we can see from this slide, not only is the patient involved in helping to plan the care, but they also have the right to participate in, be informed about, and consent or refuse care in advance of and during treatment with respect to the expected outcomes of care, including those patient-identified goals and anticipated risks and benefits, any factors that could impact the treatment effectiveness, and any changes to the care to be furnished. So just like we said a moment ago, we have to know what the plan is. We have to listen to what the patient expects, what their outcomes might be. And if those are different goals than what the doctor has ordered, we'd have to coordinate that care and maybe even explain to the patient that, yes, we heard your goals. The doctor's goals are a little bit different, however, and then explain why you have to go with the physician's orders and interventions. And then if the patient says, no, I'm not going to do that, of course, we have to coordinate with the physician. We also have to let them know any factors that could impact treatment effectiveness. Let's say you're in for wound care and the patient has diabetes. They have the right to follow their diet or not. If they choose not to follow their diet and their glucose levels are high, we would then, of course, explain to them the impact to the treatment effectiveness of healing that wound, that having elevated blood glucose levels might cause that not to happen quickly. And then the patient has the right to say, okay, well, I'll do better, or no, I won't. I'm going to eat what I want, get out of my house. That's within that patient's rights. And then we have to make the decisions internally as to what we're going to do or how we're going to communicate to the physician and go ahead and treat the patient accordingly. This slide that you see here, we notice the first bullet point, which is actually 484.50C5. This is a new standard for the COPs, and it says the patient has the right to receive all services outlined in the plan of care. So this highlights again the importance of a proper assessment and formulation of a patient-centered specific care plan, because the patient has the right to receive all services outlined in the plan of care. What does that mean? Let's say that we don't do a very good job assessing the patient, or we give vague cookie-cutter plan of care statements, and we maybe decide we're going to make 9 skilled nurse visits. And in those 9 skilled nurse visits, we're going to do 36 interventions, and we have 8 or 9 goals, okay? Now, if we don't do all of those interventions that are planned, then we just missed the standard, if that makes sense to you. So again, we have to make sure our care planning and assessment skills are honed and that we really focus in on the patient and that our plan of care becomes very patient-specific and patient-centered, okay? The second bullet, the patient has the right to have a confidential clinical record. Access to or release of patient information and clinical records is permitted in accordance with 45 CFR Parts 160 and 164. And by the way, at 45 CFR 160, it states a patient may request, or his or her representative can request, a copy of their clinical record, and that record, whether it be a hard copy or electronic form, has to be made available to the patient free of charge upon request at the next home visit or within 4 business days, whichever comes first. So keep that in mind. And it doesn't say they have to request it by written form. This could be a verbal or written request for their records. We have to make sure that it's there at either the next home visit or within 4 business days, whichever comes first. Again, talking about coordination of care, if that patient requests that record at 3:30 on Tuesday, and I got a PT going out on Wednesday at 9 a.m., we're going to have to hustle and get that coordinated and out to the patient's home, because it's not either or, it's whichever comes first, okay? So bear that in mind. The patient has the right to be advised of the extent to which payment for home health agency services may be expected from Medicare, Medicaid, and any other federally funded or federal aid program known to the home health agency. Again, beginning at time of referral, the eligibility and coverage from all the insurance types would need to be checked and documented so that that admitting clinician can explain what services are ordered, what coverage the patient has, who's going to pay, and how much is expected to be paid by that insurance, how much is not expected to be paid, how much the patient might be responsible for. That all has to be done before care is initiated. Okay, all of that has to be done before care is initiated. Agencies are required to comply with all advanced beneficiary notice requirements as well, including restrictions related to who can receive the ABN on the patient's behalf. Also note that requirements of the Medicare Provider Agreement state that agencies can't discriminate against Medicare beneficiaries. And what that means is that if an agency participates in the Medicare program and accepts a non-Medicare patient at any level of acuity, it must also accept Medicare beneficiaries at a similar level of acuity as a co-participating in the Medicare program agency. Agencies who provide services to non-Medicare patients while refusing services to Medicare patients in similar situations risk having their agreements terminated. That's something that a lot of agencies don't know about. And if you wanted to look that up on your own, by the way, that's stated at CFR 489.53A2. Again, that's 489.53A2. So if you're taking an insurance patient who has an acuity and they are going to need IV therapy, and you go out and do IV therapy for that insurance patient, but then you turn away a similar Medicare type patient who needs the same kind of care and is at the same acuity, that's a big no-no to Medicare. Okay, so just bear that in mind. A lot of agencies are not aware of that. And again, the patient has the right to be advised of the charges the individual may have to pay before care is initiated. Now, one thing I will say about this specific right is that your agency, if you're going to do private insurances especially, and those require any kind of copay, your agency has to set the policies as far as when the patient is going to be responsible for paying that copay. Is it going to be at each visit when a clinician comes and they're going to take money and go on about their business? Or is it going to be billed at each 30 days or, at the end of each episode? How are you managing that? You'll need to have your policy in place and notify the patient of the charges and when they're going to have to pay those charges. I would add that in as well. All right, still under the rights of the patient has the right to be advised of any changes in the information provided in accordance with paragraph C7 of this section when they occur. The agency must advise the patient and representative, if they have one, of these changes as soon as possible in advance of the next home health visit. I emphasize that because that's a big change. It used to be that you could notify the patient of changes in payment within 30 days, but now it's in advance of the next visit, okay? So that agency has to comply with the patient notice requirements at 42 CFR 411.408D2 and 42 CFR 411.408F. What all of that is saying basically is that the patient has the right to be advised of any changes to the extent of coverage when they occur. The agency has to advise the patient and the representative, if any, if they have changes as soon as possible, and it has to be in advance of the next home health visit. The advanced beneficiary notice requirements have to be met, and those are what you will find at the 42 CFR 411.408 D2 and F sections. Okay, so that has to do with your advanced beneficiary notice. That hasn't changed. The timeline is what's the big deal here. And again, coordinating those services to make sure that this happens before your next home health visit. That's going to be a big deal for coordination of care. Still in our patient rights, we have that the patient has the right to receive proper written notice in advance of a specific service being furnished if the agency believes that the service may be non-covered care, or in advance of the agency reducing or terminating ongoing care. The agency must also comply with the requirements of 42 CFR 405.1200 through 405.1204. What does that mean? That all is talking about your Notice of Medicare Non-Coverage form. That's CMS Form 10123, and that's for Medicare and Medicare Advantage plans. Remember, those have to be delivered at least 2 calendar days before Medicare coverage services end, or the second to the last day of service if care is not being provided daily. That's the federal guidance. Make sure you also follow any state guidance. I know here in Texas, the state guidance is more stringent than the federal on the Notice of Medicare Non-Coverage. We would actually have to, here in Texas, notify the patient at least 5 days before discharge or before something is not covered. So we have to make sure that we give those according to not only the federal but the state level regulation. A notice of Medicare non-coverage must be provided even if the beneficiary agrees with the termination of services. The beneficiary or legal representative would have to sign and date that notice of Medicare non-coverage to demonstrate they received the notice and that they understand the termination decision can be disputed. Electronic issuance is not prohibited, but the patient has to be given the option of requesting paper over electronic if they would rather. And again, go on into your cms.gov website if you need more instructions on the CMS Form 10123. And you could also look at the guidance that you see here on the slide, 42 CFR 405.1200 through 405.1204. The patient has the right to be advised of the state toll-free home health telephone hotline, its contact information, its hours of operation, and that its purpose is to receive complaints or questions about local home health agencies. Each state will need to look at and see what your state toll-free number is, the hours of operation, its contact information, and so on, and make sure the patient receives that information. This is a new standard that we see on this screen. This has to do with rights of the patient as well. The patient has the right to be advised of the names, addresses, and telephone numbers of the following federally funded and state-funded entities that serve the area where the patient resides. And I found these pretty easily by just doing a search on the internet. You'll need to look and see if there are state and federal entities for each of these. But the Agency on Aging, there's a directory on the federal site at hhs.gov, but you'll also need to look at your state. I know here in Texas, we also have a state agency on aging. So you'll need to do some research for each of these. But the 5 different phone numbers and entities minimum would be the Agency on Aging, the Center for Independent Living, the Protection and Advocacy Agency, Aging and Disability Resource Center, and then the Quality Improvement Organization. And that QIO, by the way, is who the patient would actually contact if they did not agree with being discharged or termination of services. We have to let the patient know about the QIO number. In that case, they have the right to call an appeal, and then we have a decision in that case to get back. All right, the patient has the right to be free from any discrimination or reprisal for exercising his or her rights or voicing grievances to the agency or an outside entity. That's pretty straightforward. Basically, the patient can't be discriminated against or suffer ill consequences for exercising their rights or making complaints, whether it's to the agency or to the state or an outside entity of any kind. And then we also have on the 12th right, the patient has the right to be informed of the right to access auxiliary aids and language services as described in paragraph F of the section. That's going to be the last part on accessibility that we'll get to in just a moment, and how to access those services. So we have to offer these auxiliary aids and language services to the patient. If they don't want to use them, we should document that they declined, but certainly they have the right to be informed about their right to access the auxiliary aids and language services. All right, the 4th of the 6 new rights standards relates to transfer and discharge. It's found at 484.50D. The patient and the representative have a right to be informed of the agency's policies for transfer and discharge. The agency can only transfer or discharge the patient from the agency if one of the following is true. The first of these, the transfer or discharge, is necessary for the patient's welfare because the agency and the physician who is responsible for the home health plan of care agree that that agency can no longer meet the patient's needs based on the patient's acuity. The agency must arrange a safe and appropriate transfer to other care entities when the needs of the patient exceed the agency's capabilities. So first of all, here we see that if the physician who's responsible for the plan of care and the agency agree that the agency can no longer safely meet that patient's needs based on their patient's acuity, the patient may be transferred or discharged. But notice the agency must ensure safe and appropriate transfer to other care entities. I would expect to see well-documented communication and coordination with the physician, the patient's representative if they have one, and the facility that's including a care care summary, current reconciled medication list, and transfer information to the place where that patient's transferred, and also to the physicians or personnel who's going to be responsible for that patient's care at transfer or discharge. So this is not a short-term or an easy process. It would need to be documented from the first point that you realize that you're not able to really meet this patient's needs, and you're coordinating with the physician, and you're calling facilities and helping arrange the patient's transfer or discharge, and so on. All of that should be documented in your records. The next reason that the discharge or transfer of the patient can occur is that the patient or payer will no longer pay for the services provided by the agency. Number 3 is when the physician who's responsible for the plan of care and the agency agree that the measurable outcomes and goals in the plan of care have been achieved and the patient no longer needs the agency services. In other words, the patient's health and safety has improved or stabilized sufficiently that there's no longer a need for the services. The fourth reason for transfer or discharge would be if the patient refuses the agency services or otherwise elects to be transferred or discharged. For example, they may elect a hospice benefit, or they don't want to use up all their benefits. Lord knows I've heard that many, many years of my nursing career in home health, and you really have to explain to the patient, you're not going to use up your benefits for Medicare. It's an ongoing process, and, sometimes they understand, sometimes they're adamant that they want to be discharged. Or maybe they want to transfer to an agency where a friend or family member works. Those are all reasons under the fourth transfer and discharge reason here. Reason number 5, this one gets a little more sticky. This would be for cause. Basically, the agency should develop a policy as to what transfer or discharge for cause means. So we see in this standard, the agency determines under a policy set forth by the home health agency for the purpose of addressing discharge for cause that meets the requirements of paragraphs D5.1 through D5.3 of this section, that the patients or other persons in the home, their behavior so disruptive or abusive or uncooperative that delivery of care to this patient or the ability of the agency to operate effectively is seriously impaired. And the agency has to do several things before you discharge a patient for cause. Again, you're really looking at something that is so bad you just can't safely render the care. And I'll give you an example. This actually happened to me when I was doing home health nursing in Nashville. Not to me personally, but I was a supervisor, and we had staff members who were seeing a patient who was a quadriplegic from a gunshot wound that he suffered while he was dealing drugs. And we went into his home. He had wounds on his legs that needed to be attended to. And there was so much criminal activity, including still drug dealing and even some prostitution going on in the back room of that apartment, that the skilled nurses were unsafe and disruptive. It was real disruptive to care, I should say. And so for that reason, we had to coordinate with the physician. And, we tried some other things. We didn't just discharge the very first visit, but we had to talk to the physician. We tried going earlier in the morning. We tried talking to the patient. Patient shared the home with someone else, and so it just didn't work that we could keep that patient, and so we had to transfer him somewhere else. We did teach a caregiver some wound care, we notified the physician, we got a social worker involved, and so on, and the patient just wouldn't move. It was just a bad situation, and we couldn't effectively render care and do that safely because the environment was just so disruptive. So again, you have to figure out, first of all, if this is going to be something you can deal with as an agency, and then you have to do the following before you discharge a patient for cause according to the new COPs. You would have to advise or notify that discharge for cause is being considered, first of all. And who all would you notify? That would be the patient, the representative, if they have one, the physicians giving orders on the plan of care, and then the patient's primary care professional who's going to be responsible for providing care after discharge. And so sometimes notifying those people will stabilize the situation. They'll realize, oh, wow, if this nurse can't come in, we are going to have to take Dad somewhere and get his wound dressing done, and that's not convenient, and so let's just make sure that everything's under control and this nurse can come in and out. Sometimes that works, sometimes it doesn't. So you'll need to make sure that you have a policy and that you're following that policy for cause and that you're doing all the following things. That's the first of the things you have to do. The other things you have to do before you discharge for cause, you need to make efforts to resolve the problems presented by the patient's behavior. For example, go earlier in the morning before the drunks get up if you're in a bad neighborhood. I've done that before. You might provide the patient and representative contact information for other agencies or providers who might be able to provide care. And then, of course, you would need to document problems and efforts made to resolve those problems before you discharge. Remember, you got to give that 2-day notice of non-coverage or termination of services before you discharge the patient as well. We also see 2 more reasons that you can transfer or discharge, and these are pretty self-explanatory. Number 6 and 7 is if the patient dies, and number 7, if the agency ceases to operate. Now, a couple of examples that you might think about that are not covered here. Notice unexpected staffing shortages and face-to-face encounter requirements not being met are not reasons in these 7 for discharge or transfer. Again, and CMS actually said this in the final rule and the comments that they made and the responses, that agencies are responsible for assuring adequate staffing at all times to consistently meet the needs of all patients under their care. So you can't discharge them after the fact because you're short-staffed. Sometimes that might mean that you as a supervisor has to go out and make this visit. It may also mean that you don't take them at the beginning. You don't admit the patient because staffing is so short. Those are decisions you'll have to make in your agency, but it certainly is not a reason to transfer or discharge after you've admitted the patient. You'll also notice in the event coverage requirements are not met, an agency would be permitted to discharge a patient because the patient or the payer will no longer pay for the care. That is an approved reason, and that's really where that face-to-face encounter requirement comes into play, because a face-to-face encounter is part of the certification process, and if that's not met, of course, Medicare's not going to pay. You can, at that point, notify the patient and come out of the home for non-payment. But remember, the best practice is that certification and face-to-face process is completed before you admit the patient in the beginning. Standard number 5 of the 6 of the patient rights is investigation of complaints. And you'll see here on the slide, the agency must investigate complaints made by the patient. And that includes, but not limited to, treatment or care that is or fails to be furnished, treatment or care furnished inconsistently or inappropriately, mistreatment, neglect, verbal, mental, and sexual and physical abuse, and injuries of unknown source. Now, that's something we are going to talk about for just a moment here. When you look at the injuries of unknown source, what does that mean? CMS laid that out for us in the final rule, and here's what they said. In order for an injury to be classified as an injury of unknown source, both of these conditions have to be met. Number 1, the source of the injury was not observed by any person, or the source of the injury could not be explained by the patient. And then reason number 2 is the injury is suspicious because of the extent of the injury or the location of the injury. So, for example, the injury is located in an area not generally vulnerable to trauma, or they have a number of injuries observed at one particular point in time, or they recur over time. So again, those are what you call injuries of unknown source. Nobody saw it. The source of the injury couldn't be explained by the patient, and then the injury and extent or location is such that something is just not right. And we know we've all been in those situations before where you have that go on. Also, misappropriation of the patient's property by anyone furnishing services on behalf of the agency, that also has to be investigated. And complaints should not be investigated by, of course, the home health staff involved in the complaints. So if the patient complains about a staff member, don't use that staff member to go and investigate what's going on. That's kind of common sense, but clearly it must have been a problem for CMS to bring that up. You'll see at 484.50E 1, 2, and 1.3 that the agency should have a complaint log, an investigation process, and documentation forms for complaints, because the standard says the agency must document both the existence of the complaint and the resolution of that complaint. And then we have to take action to prevent further potential violations, including retaliation when that complaint is being investigated. Now, your surveyor is going to want to see your complaint log, the investigation records, and so on, especially if they're coming for that 800 hotline number. The agency has to document the existence of the complaint and the resolution. If no complaints are ever documented, then there's a problem somewhere, because we know good and well patients and caregivers complain. So if you're not getting that documented when you review for QA, you probably want to do some staff education. Document everything, even if it's felt to be unfounded, and investigate it. Take action to prevent further violations, like changing the staff members going, or making sure you do supervisory visits to check on skills if there's a complaint about a clinician's skills. All right, the next standard, you have investigation of complaints. This basically says if staff, whether that be employees that are full-time or part-time or contract, identify or notice or recognize the circumstances of mistreatment, such as neglect or verbal, mental, sexual, or physical abuse, or injuries of unknown source, or misappropriation of patient property, they have to report that to the home health agency immediately and other appropriate authorities in accordance to state law. One thing I will say about that, again, make sure you educate your staff on who it is that's actually going to do the reporting once it hits the home health agency level. For example, you may not want your visiting clinician calling the abuse hotline in your state or calling the police and that kind of thing if the patient says that somebody has taken something from their home. Now, you also don't want to slow down that process in any way, so you'll need to figure out who in your agency would be responsible for making those types of calls. Is it the administrator or the director of clinical services or the case manager? And then make sure you educate your staff on what they should do. If the patient complains that someone stole a checkbook or they stole something of value in the patient's home, even if it's not of value, they stole a pen, you still have to document that and report to the appropriate authorities in accordance with your state law. Just make sure that you have those policies, revise those policies, you adhere to them, and that your staff understands what's going on and who they should report to. The sixth and last of the patient's rights section is accessibility. And what this tells us is that information has to be provided in plain language in a manner that's accessible to persons with disabilities. So when you think about that, think 8th grade level plain language notifications, right? The provisions of the Americans with Disabilities Act and Section 504 of the Rehab Act require that facilities provide equal access to individuals with disabilities. If the provision of auxiliary aids becomes an undue burden, the agency may seek protection that's available under Section 504 of the Rehabilitation Act. But what this basically is talking about with accessibility is that you have to give alternate formats, such as qualified interpreters, large print documents, Braille, digital versions of documents, and audio recordings if need be. You'll also notice that the information has to be provided to patients in plain language and in a manner that is accessible and timely to persons with limited English proficiency through the provision of language services at no cost to the individual, including oral interpretation and written translations. Now, CMS does not expect the agency is going to present a translated document to every single patient in their native language when they're admitted and before giving care. Understandable doesn't mean it's expected to be written in every language. General understanding means the patients achieve a grasp of the explanation of something, not necessarily it's a verbatim written translation. But CMS does expect agencies to use available technology like telephone interpretive services and or patient-selected translators. Now, your languages that are common are going to vary by the areas in which you are located. Things to think about, your notice of rights can be translated once, for example, and then you can use that document over and over and over. I know here in Dallas, where I'm located, of course, Spanish is a big language here. We do have some Farsi. We do have some Vietnamese and Korean languages. So I would want to do some research and see what are the top languages in my area and make sure that we translate over the patient rights in those particular languages. Now, if we come across some language that we seldom ever get, maybe Armenian or Russian language, that's not real common here, but we would have to give them some kind of understanding of their rights, but it wouldn't necessarily have to be translated in their language in that case. The patient should be informed of the availability of professional interpretation services regardless of whether or not the patient offers to provide an interpreter. Next, we're going to learn about Section 484.55, the comprehensive assessment of patients and related changes to the COPs. What you'll notice at the preamble at 484.55 is that each patient, not just those receiving skilled care services or those who have Medicare or Medicaid as a payment source, it's in the best interest of patients that each patient must receive, and the agency has to provide a patient-specific comprehensive assessment, okay? Now, that patient assessment is designed to identify the patient's needs, and all patients are going to have needs to be assessed, right? So all the patients have to be assessed, otherwise they wouldn't really need to be receiving home health services in the first place. Now, for Medicare beneficiaries, the agency also has to verify the patient's eligibility for the Medicare home health benefit, including homebound status at the time of the initial assessment and at the time of the comprehensive assessment. And we know that's a big deal right now in our environment because we're seeing this in all kinds of prepayment reviews. We're seeing it in payment probes. We're seeing it with our face-to-face encounter requirement reviews, pre-claim review, all of that regulation. It's a big deal that the patient meets the criteria to receive the benefit in the beginning, including the homebound status. So the eligibility for Medicare home health benefit, again to review, the patient has to be under the care of a physician who establishes and periodically reviews that plan of care. The patient has to require a skilled service. They must have had a face-to-face encounter with the physician. They require skilled services that in their homebound. We know that with the pre-claim review and certification and face-to-face audits and so on, that's a big deal. The initial assessment visit. There are no changes here except the location of where this is found. The initial assessment visit still has to be held within 48 hours of referral, still has to be held within 48 hours of the patient's return or on the physician's ordered start of care date. In the final rule, however, CMS stated if the agency is unable to begin care on the physician-ordered start of care date for any reason, CMS expects the agency to decline the referral because it's unable to meet the patient's needs in a timely manner. Now, I will say this does not include when the patient refuses. If the doctor says, I want you to go out on Saturday and admit this patient to home health care, and you call to make that visit, and when you're setting that appointment, they say, oh, no, Saturdays are not good. You're going to have to wait and come on Sunday afternoon. You would have to, of course, notify that referring physician and let them know that information. And that's why it's important to call ahead. Don't wait till Saturday morning. Call on Friday when you get that referral. But you have to let the physician know. And if it's the patient who's refusing, that's a different circumstance than you look at your staffing and see, oh, we're all full on Saturday. Let's just do it on Sunday. If you can't do it when the physician orders it, then you need to give someone else that patient for timely initiation of care reasons. CMS was very blunt. They said this, and I put it in quotes. It is not acceptable for an agency to seek a new referral with a new start of care date that is more convenient for the agency. And that's a practice that I have seen several times when reviewing home health charts. Agencies realize, oh, we're full on Friday. Let's just call the doctor and let them know that we can't go Friday and we'll get a new start of care date for Saturday. CMS point blank says that is not acceptable. It is not acceptable for an agency to seek a new referral with a new start of care date that is more convenient for the agency. All right, so don't do that. CMS will get you. The surveyor will get you. This also has not changed. When rehabilitation therapy service like speech or PT or OT is the only service ordered by the physician who's responsible for the home health plan of care, the initial assessment visit can be made by the physical therapist or the speech-language pathologist. So if this is an admission, PT and speech can go out and see Medicare patients, right, and do their start of care if nursing is not involved. OT cannot open Medicare cases, but they can do research, right? They can do resumption of care, but they can't start the patient. OT can open for non-Medicare cases like private insurance. or to recertify when OT is going to continue on a Medicare patient. So make sure you know your policies, especially if your policy is that an RN does all initial assessments and comprehensive assessments, and PT goes out and does the eval. If that's your policy, you need to make sure that that comprehensive assessment and the Oasis is done on the same day as the therapy skilled service occurs. So if RN's open all care and RN is not ordered for home health on this patient, the RN has to go and do the comprehensive assessment the same day as the physical therapist or the PT or the OT or whoever's going out there, because the first billable visit becomes your start of care date. Remember also in those scenarios, your notice of rights has to happen before any care is initiated. So the RN can't go out and do the comprehensive assessment after the PT's already been out there, unless that PT is going to go ahead and go over the patient rights with that patient and give that written notice. And if that's the case, make sure that's well documented so the surveyor will understand what's going on. The comprehensive assessment must be completed in a timely manner, consistent with the patient's immediate needs, but no later than 5 calendar days after the start of care. Again, if you're going out on Monday and you're doing your comprehensive assessment and you provide a skill service, Monday is day 0, Tuesday counts day 1, and you have 5 calendar days. That is not just to finish an Oasis document. That is to continue to gather information. You should finish that up as soon as possible, but you do have 5 days if you need to confirm a diagnosis or reconcile medications, for example. You also see in the second bullet here that except as provided in paragraph B3 of this section, which is coming next, a registered nurse must complete the comprehensive assessment and for Medicare patients determine eligibility for the Medicare home health benefit, including homebound status. And this is one reason a lot of agencies go ahead and have the RN do everything. But note on this next slide, when PT, speech language pathology, or OT is the only service ordered by the physician, a physical therapist, SLP, or OT can complete the comprehensive assessment and for Medicare patients determine eligibility for the Medicare home health benefit, including homebound status. The occupational therapist may complete the comprehensive assessment if the need for occupational therapy establishes program eligibility. That last sentence is key. Occupational therapist cannot establish program eligibility on a start of care. You're going to find that in your Oasis guidance. Your Oasis guidance manual will tell you that, as well as Q&A. So again, if you don't already know that, OT cannot open a case or do an admission, but they can do recertifications. Next, we see the content of the comprehensive assessment, and we see some new information here. We see here that the comprehensive assessment must accurately reflect the patient's status and must include at a minimum the following information. We see the patient's current health, psychosocial, functional, and cognitive status. Now, psychosocial status refers to an evaluation of his or her mental health, their social status, and functional capacity within the community by looking at issues surrounding both their psychological and their social condition. For example, their education, their marital history. And that's intended to screen for potential issues that might complicate or interfere with the delivery of the agency services and the patient's ability to participate in their own care. The cognitive status refers to evaluation of the degree of his or her ability to understand, remember, and participate in developing and implementing the plan of care. Numerous tools are available for screening their cognitive status. CMS does not require any one in particular. A resource list is listed on page 116 of the final rule if you need that. One of the tests that I've used in the past is the CLOX test, CLOX test. That's a pretty easy test to use. It is standardized. You basically go in with a piece of paper that has a round circle on it, a dot in the middle, and that represents the face of a clock, and you would instruct the patient to draw a long and short hand to indicate a certain time. For example, it might say 2:05 p.m. Okay, so then you can tell pretty quickly if the patient's cognitively with it enough to make the clock say 2:05. Okay, so that's a real good one to use. But again, CMS does not have any certain one that they recommend. It's up to you and your policies of your agency to determine what you're going to use to assess their psychosocial and cognitive status. The next thing you're going to see in the second little dash here, the comprehensive assessment must accurately reflect the patient's status and include the following: the patient's strengths, their goals, their care preferences, including information that can be used to demonstrate the patient's progress toward achievement of the goals identified by the patient and measurable outcomes identified by the agency. The goal of these requirements, of course, is to enable your agency to develop a patient-centered, complete plan of care that truly implements a good understanding of the patient. Patient strengths may be things such as knowledge of medications or their motivation or readiness for change, their vocational interests, their interpersonal relationships and support system, and their financial stability. You'd also need to identify deficits and strengths to understand that patient. For example, if the patient prefers a shower instead of a tub bath, that should be understood and accommodated to what degree that's possible. What days the bathing needs to occur. If the patient wants to get a bath on Tuesday and Thursday, we should do our best to accommodate those when possible. The comprehensive assessment must also accurately reflect the patient's status and has to include the following information: the patient's continuing need for home health care, their medical, nursing, rehabilitative, social, and discharge planning needs, a review of all medications the patient is currently using in order to identify any potential adverse effects and drug reactions, including ineffective drug therapy, significant side effects, significant drug interactions, duplicate drug therapy, and noncompliance with drug therapy. Again, we know that medication reconciliation is a big part of what we do. It's also a very big risk for patients going back into the hospital after they've been discharged. And quite often we find that the discharge list from the facility does not match what the patient actually has in the home. So we have to do a very thorough review of what the patient has. Don't make it a habit to write what's on the discharge paper. Make sure you lay eyes on the patient's medication bottles. Ask them for over-the-counter drugs. And of course, we know from practice those medications are all over the house. They're in the kitchen. They're in baskets in the bedroom. They're in the lavatory or the restroom. There may even be medications in the patient's handbag or in their nightstand. So we have to do a really good inspection and look at expiration dates and the dates that they were filled, because if medications are expired, for example, that could be a problem. There's often also problems with patients taking digoxin and lanoxin at the same time because they don't realize it's the same drug. So that's really one of those things that the comprehensive assessment is trying to ensure, is that we're looking at all of those medications, we're reconciling them, and then we're looking for any kind of drug reactions or ineffective drug therapy. It's not managing their symptoms, significant side effects, drug interactions, duplications, and noncompliance. And sometimes you can simply count the number of tablets in a patient's prescription bottle until they're not compliant. And I'm glad nobody's doing that with my medications, because I wouldn't do a very good job, I'm afraid. All right. We also see that the patient's primary caregiver, if any, and other available supports, including that caregiver's willingness and ability to provide care, the ability and schedules of that caregiver, and then the patient's representative, if any. Of course, we need to know that caregiver's willingness and ability and availability and their schedules, because we can't develop a schedule for turning a bedbound patient, for example, without knowing when the caregiver is available to perform the task, right? So you really need to know that information in order to do a thorough, comprehensive assessment. And these are now condition level problems if we don't. We also see the comprehensive assessment must also include incorporation of the current version of the Oasis. That's nothing new. The Oasis is changed and updated according to the Secretary, the Health and Human Services Department, and the Oasis has to have all of the following items in it as you see here. We see the Oasis has to include clinical record items, demographics and patient history, the patient's living arrangements, supportive assistance, sensory status, integumentary status, respiratory status, elimination, neuro-emotional behavioral, ADLs, medications, equipment management, emergent care, and data items collected at inpatient facility admission or discharge only. What does that mean? That last part just means the items that are only on a transfer form, for example, or a discharge form as appropriate with that type of Oasis situation. We also see that the comprehensive assessment has to be updated and revised as frequently as the patient's condition warrants due to a major decline or improvement in the patient's health status, but not less frequently than the last 5 days of every 60 days, beginning with the start of care date. And of course, that's our research, right? Unless there's a beneficiary elected transfer or a significant change in condition, and then discharge and return to the same agency during a 60-day episode. What does that mean? You should have a policy that defines what a significant change in condition is and when that would trigger an update to the Oasis. In other words, when are you going to do a follow-up Oasis, what we used to call a SCIC? A lot of agencies got away from doing this when they realized that it does not affect your payment at all mid-episode, but it's still, as you can see here, mandated that we update that comprehensive assessment if the patient's condition warrants, either because they got a lot worse or a lot better. And so what are some examples? If you initiate or discontinue a service, and these examples came from the COP comments, by the way, and not just Jennifer Gibson's reasons. But CMS says initiation or discontinuation of a service, significant improvement in condition, significant worsening of a condition that was not anticipated in the plan of care. And some specific examples they give are extended emergency room stays, being kept in observation status for a period of time, utilizing urgent care. Those are all examples of significant changes in condition. You also notice that the comprehensive assessment has to be updated within 48 hours of the patient's return to the home from a hospital admission of 24 hours or more for any reason other than diagnostic test or on physician-ordered resumption of care date and at discharge. So all of those reasons indicate that you need to do another Oasis, okay? So we've covered the patient's rights, we've covered the comprehensive assessment as they relate to the updated COPs. So what should your agency do now? Again, familiarize yourself and your staff with updates to the conditions of participation. You need to identify the primary languages spoken in your home health agency's coverage area. Locate or translate patient right notices in those languages. Identify translation services technology you can use, such as a phone service. Form an interdisciplinary conditions of participation implementation team. Their job would be to review and update your policies and update forms as needed. And then you'll need to identify educators and preceptors for implementation of the COPs. What else should you do? Review your referral intake processes, including insurance coverage processes. You want to make sure that you're reviewing the coverage not only before the care begins, but periodically, because of the new timeline in which you have to notify the patient by the next visit. You'll need to make sure that you're aware of the changes in their insurance and that you have time to coordinate that information before the next visit. And then, of course, you want to begin refining your assessment and care planning processes, especially if you're one of the agencies where the Oasis is done by the field staff and the QA department does all the diagnosis coding and not just adding the code itself, but actually sequencing the codes and writing your 485 plan of care. As you can see with the new COPs, that is not what CMS is looking for. And then last, you'll want to speak to your software vendor about planned changes to ease your regulatory burden. The last thing you can do, of course, is join us for the remaining webinars in this 7-part series where we're going to train on new and revised COPs, including your skilled professional services and home health aides, your care planning, coordination of services and quality of care, your QAPI, your infection prevention and control, and emergency preparedness. In closing, feel free to email or message questions to me at jgibson@axxess.com, or you can call and leave a message or even text message at 972-975-0417. That is my cell number. Feel free to let me know if you have questions, and I'll get back to you just as soon as I can. And thank you again for trusting Axxess for your education needs. I've enjoyed being with you today, and I will see you again soon. Thank you. Bye-bye.
Thank you for joining our on-demand training today and for choosing Axxess, a provider of innovative, cloud-based software, services, and solutions to help home health organizations improve patient care and grow their business. Axxess is the only healthcare technology company approved to award continuing education credits by the American Nurses Credentialing Center and is also the most recommended home health software on Software Advice. You can watch more on-demand training videos through our software or at axxess.com, where you can also find tutorials, blogs, white papers, and answers to frequently asked questions. Thanks again for choosing Axxess.